Hello and welcome to the Bill Gephardt Show podcast. I'm Bill Gephardt. Now, today I am delving into a need that I think is largely ignored maybe in our culture and our society, but growing exponentially in our world. And that is home care for the elderly, health care for the elderly in the home, and eventually end-of-life care with dignity, often referred to as hospice care. Now, if you look around, you can see the growth in elderly care needs for aging baby boomers. For example, there are these huge multi-story assisted living centers rising up everywhere. And it's various levels of assisted living, from, apartments where residents still drive their cars and park in the garage underground, maybe live privately in an apartment or condominium. They have eating, home maintenance, and recreational needs there, but those might be covered. And then there are all levels of this stuff, all the way to, for example, memory care, maybe full nursing facilities, and eventually end-of-life hospice care. But many want to remain in their homes. They don't want to go somewhere else. But as they age, it becomes more and more difficult. The home health and hospice industry spending in the United States, it's growing. It's doubled from $100 billion in spending in the past decade to $200 billion, according to one source I found. Now, joining us now to help understand all of this, I've invited some people from the company named Auburn Crest Home Health and Hospice. They are based in Idaho, and they have several offices, especially and including where all three of these people work in Utah. So let me introduce David Woods. He's a registered and longtime practicing nurse who owns this Auburn Crest location, or at least he manages, let's put it that way, in Utah. And also with us, Jenna Wilburn, who has a lot to share about what they do, and registered nurse Jessica Barnes, who is the director of nursing. Welcome to all of you.
Thank you.
Thank you.
Thank you.
Sure. First to you, David, if I may. What got you into this industry from other medical care that you have provided in your career as a nurse?
Well, I started as a nurse, as many do in a hospital, and really was not fulfilling. Taking care of people is, but you don't get to know them. You see them for a day or two, and you don't really know that you made a difference or they got better, or really what happened to them.
Yes.
I had some relatives in my family who were elderly and injured and went into a skilled nursing facility. And so I started looking at something that was a little more meaningful. So I started working at a rehab center here in DRAPER, and realized quickly that geriatrics was going to be my nursing passion, and taking care of people through the end of their life. Eventually, my great aunt went on hospice, and I saw the special work that they do. I mean, it's amazing what hospice and home health is, and then it clicked for me that this is what I was supposed to be doing. I became a nurse later in life after another career, insurance. So I was 38 when I started nursing.
Yeah.
And so at that point, I was like, I could do this for the rest of my career. And I went to a hospice company, home health, learned the ins and outs of the business.
There you go. And now you're hooked up with Auburn.
Yes, I've been with Auburn Crest for about a year. The other company sold, and so I still have a decade left to work. So now here I am with the new company, and the team we have is amazing.
Beautiful. Jen Wilburn.
Yes.
This is something that is, I think, a bit of a calling, isn't it? There are a lot of things that people could do, but it's a calling, isn't it? What do you do, and why? And what do I mean by that?
It is 100% a calling. I am the marketing director for Auburn Crest Home Health and Hospice. My job is to meet families in home, in skilled nursing, in assisted livings, hospitals, and to explain and help them understand the services that are available and help them feel comfortable with
what is it you do? What do you tell people when you go into their home? I mean, I have to assess the situation, I guess, right?
Correct. I have to go in and I have to, like you said, assess the situation. What are the needs? There can be some needs on a piece of paper written by a doctor, but you get into someone's home and there may be other needs.
What are they? Yeah.
There could be needs for medication management. We walk into a home and there's pill bottles all over. Obviously, we need to help these elderly people manage this medication.
What if a place, sometimes you walk into places a mess and they have not seen a patient, a client, whatever you call them, or haven't seen relatives or neighbors or anyone in months.
Right.
How do you fix that?
In those situations, we reach out to some of our partners who do private duty caregiving, which is the home housekeeping, the laundry, those kinds of things in the home. Our job is to be the medical side of things. Physical therapy, occupational therapy, nursing, wound care, whatever their needs are, that's our job. But our job is to assess the entire situation. And it's also to not only take care of the patient, but also help the family as they're trying to navigate very uncharted waters. That's the thing I run into the most is we have no idea where to even start. And so it becomes a conversation.
You know where to start. It's the family that has no idea. But the family has no idea. Yeah.
I know where to start. And sometimes it's just listening long enough to let them explain frustrations, let them vent a little bit, and then come in and say, I've got the answers to that. Don't worry. We're going to walk through this. We're a team. We have the resources that you need, and we're here to walk this road with you.
We are still talking about the home healthcare portion of your business. Correct. And I want to talk to Jessica now about you're the nursing director. You're in charge of hiring the nurses who work for you. And after Jen assesses the needs, you have to have nurses to go in there. What are you looking for when you hire a nurse? I would think it would take a special kind of nurse.
Well, what I'm looking for is somebody who is kind and compassionate. In home care, when you're caring for people in the community, it's really important to also be very organized. Because we're not just in one doctor's office treating a patient that's going to be seen in a room and then go home. We're treating that patient in the home throughout our community. So we could have a patient in, let's say, Rose Park, and our next patient is Claire out in Harriman. So scheduling and being organized and knowing how to capture such a wide demographic is really, really important. But really, just that compassionate heart that has a genuine care for patients who wants to make a significant difference is what a community home health and hospice nurse is.
What is it you do? I mean, a nurse walks up to the door every day, every other day, every week, and knocks on the door. And what happens from there?
So when we're seeing patients in their home, it depends on, like every situation is different. So you can have a patient that has an infusion that we go see every single day if they have that need. We could have a patient that has a wound, and those patients may be seen normally on Monday, Wednesday, Friday, if that's what that need is. So we're just drawn to this. It's not scary for me to go knock on somebody's door and introduce myself for the first time, walking into somebody's home. Like, it just is what we do. And I feel honored to get to do that.
David, who pays for all this? How do I even think about contacting a company like Auburn Crest? I don't know. I don't even want to talk to them because I'm positive I can't afford somebody coming around to my house, I might say. How do we handle that for average earners, I guess, or anybody? How does that work?
Well, it's not out of pocket. I mean, it's through your insurance. Medicare and most insurances have a home health and hospice benefit. So we have contracts with insurance companies, and of course Medicare, and we bill them like any doctor's office or hospital provider would. So those things are paid for you have those
Okay, so
benefits.
there's nothing you're telling me there's nothing to be worried about. At least make the phone call and get a proposal, right, David?
Yeah. So what happens is a doctor or a hospital will send us discharge orders and a history and physical and insurance information. Of course, we can't do anything without a physician's order. So we read over all that information. We check the insurance information and make sure it's good and contact the patient. We explain the benefits to them when we start, what's covered, what's not. In home health care, everything's covered. That's related to your diagnosis. Excuse me. And so those things are worries that they don't need to worry about.
All right. So let me ask Jessica something that I think might come up. You tell me. You're the expert. I'm not. Jessica, what if I don't want any of these damn strangers in my house? Keep them out of here. And yet they have a need. How do you handle that? Does that come up?
It does come up. And so when those situations arise, normally what I do is I look at what's most important for this patient. So let's just say we got an order from a doctor that needed physical therapy, occupational therapy, and nursing. Okay. But when you're looking at this referral, you can sometimes determine what is the highest need. So normally we always are going to send in a nurse and have them assess what that need looks like. I have been in homes that are hoarder homes. And these homes are very protected by their patient, right? That's their sacred thing. And
it's in my family. Maybe that's why I asked. I don't want anybody coming into my home. That's right.
We respect that. And I do tell them, I'm not here to look at your home. I'm not here to look at your surroundings. I'm here to look at you, and I'm here to help you as a person, help you get better in your health, so that if there's other things that you want to address, you have that ability to. And I just really respect that space. And I have been in those homes where they're stacked from floor to ceiling with newspapers, or floor to ceiling with the oddest one was cups from a Maverick cup. They just never threw away a cup their entire life. And we get to respect that.
That's a hoarding thing, yeah. Mm-hmm.
Yeah, it's their space. There has been times when the situation's unsafe. As the director of nursing, when you walk into a home that might be cooking meth or heroin, we get to determine what's our safety level and what's our comfort zone with that. And normally we have to.
Well, wait a minute. It's not the senior citizzen necessarily who's cooking the meth and heroin. Yeah.
No, but we treat everybody. We do treat everybody.
I see.
So, I mean, there is. We have to be safe as well, as what I'm trying to say, because you asked me that question, what do you do? We do have to keep our clinicians safe. That's David and Jen and mine's priority. But ultimately, we respect people in their homes, and we're here to serve them, and we give them what they need.
I think you've gotten me into an area that has taken me away from the senior population. You're talking about anybody, whether they're 20 years old or 80 years old, who needs home health care.
Yeah. So, you could have one patient that I had a while ago was a younger wound patient that was about the same age as my kid, but he had a wound vac. So you literally, so on the home health side, not hospice, and sometimes hospice patients can be younger. I mean, tragically, we all do end up getting cancer or something and could end up needing hospice. But on the home health side of things, yes, we're going into a population that, we don't do pediatrics. So normally our population is 18 and over. We can do infusion. We can do, we do lots of things in the home setting to keep the patient out of rehab, like a skilled rehab facility whenever possible. It's not always appropriate. We want to do the appropriate level of care.
Yes, you do. Jen Wilburn, you get to, when you have someone for sometimes years, you get to know the family, don't you?
You do. It's a lot of times, as I look at it, we are caring for the patient, but we are also caring for and educating family members so that they feel comfortable with the situation that's going on. There can be some hand holding And like I mentioned before, a lot of times they call and their first comment is, I have no idea where to start. That's my job.
That's right.
That's my job. I'm going to hold your hand and we're going to take these steps and I'm going to guide you step by step as to what we need to do. So then it becomes not just the patient, but it could be husband or wife. It could be children. It could be grandchildren that we are now taking on this journey with us. And everybody is more educated and I hope more comfortable with what's happening.
That is the key. I don't know where to start, and I might not be the patient. I might be the child of the patient or the grandchild of the patient or the friend of the patient. And I've been in and out of this home so many times and I just don't know where to begin, but you do.
We do.
Okay.
And we're happy to help.
We're talking about home health at this point for Auburn Crest Home Health and Hospice. When we come back, I want to delve into end of life with my panel here, end of life hospice, which they also do. We will be right back.
It's recording right now. That's the rear end there. That's the front facing you right now. The camera's on you right now. It's recording.
Ready? All right. Let's do it. Woo! This is amazing! This is awesome!
Welcome back to the Bill Gephardt Show podcast, and we're talking about home health and hospice with three people who work at Auburn Crest Home Health and Hospice. It's an organization that is based in Idaho, and they have several offices, and one of them is in Utah, and that's where David Woods, the administrator, comes from. He's here in Utah. Jen Wilburn is the marketing director, and Jessica Barnes is the nursing director. David, fully 50% of your business, you tell me, is hospice, which is end-of-life care with dignity, right? How has that evolved?
What we do is come and assess the situation, the family, the dynamics. We have chaplains, social workers. We still can do physical therapy if it makes sense to keep people mobile and what we do is we really make sure that we're addressing the issues of the disease, make sure that you're out of pain. Our physician works closely with us. He will go out to the homes and do visits if necessary. We work with nurse practitioners. And so it's an entire team approach to take care of everybody, including the patient and their families at home, and just to make sure that the rest of their lives are as comfortable as possible.
Everybody's different. Every situation is different. Isn't that right, Jessica Barnes, the nursing director at Auburn Crest.
That is correct. Every situation is very, very different. Each patient has, they could have the exact same terminal diagnoses, but what that's going to look like for each of those patients is going to be very, very different.
How do you handle this? How do you handle it? I mean, I would think if you've been with somebody doing healthcare for a while and now they're in hospice and you know the family and you know the patient, that can be heart-wrenching, I'm guessing, not just for the family, but also for your nurses.
It is heart-wrenching because they do become family to us. So when you have a home health patient that you've treated for a long time, and they do transition over to hospice, and it's nurse, not all nurses do home health, and not all they don't do hospice. Some nurses are only home health. Some nurses are only hospice. So what I like to say about me is that I do both. So I get to see both sides and support that family through their entire process. And that's kind of an honor to me. It definitely is hard because you do get emotionally attached, but at the end of the day, what an honor to get to serve.
Jen Wilburn, marketing director. I heard for the first time when I talked to you guys, when I came over to your offices, that when a patient is after hospice, it becomes deceased. You don't walk out the door at that point. What is it? A 13 month? What's the 13-month continuation of services? What's that?
So 13-month continuation of services for the family. We want to get past the first Christmas, the first birthday, the first wedding anniversary, and the first anniversary of the patient's passing. Families need to be supported. They need to have social work. They need to know that when they say, I'm not okay, they have someone to call.
What do you do? And obviously it's emotional. It's emotional it's emotional for me just talking to you, for crying out loud, because I've had some of this in my family. But what do they do? Do the family members call you and say, I'm feeling bad? Or do they, how does this work?
They can, but our social worker and our chaplain do regular follow-up calls with them, bereavement calls, check-in calls. Not every family, not every person is going to say, I'm going to call somebody and tell them I'm not okay with what's happening. Not everybody's going to say that. They're going to suffer in silence. So part of our job is to reach out and ask the question, how are you? What can we do? It might be they just need a phone call. It might be that they may need some extensive counseling therapy, and we may need to direct them to somebody who can help with some other issues. Our job is to make the phone call and ask the question, how are you? How are things? And to also assess that they're grieving appropriately and we don't see any red flags or any warnings that would kind of raise some questions.
Like
we want to take care of their mental health.
What do you notice sometimes? What is a behavior that probably needs a little extra attention from a family member who has lost someone?
So I've encountered over the years that there will be maybe a family member who's very stoic, never sheds a tear, never seems to have this be emotional, isn't reacting to this. And so it's okay for a little while to kind of sit in that, but people cannot sit in grief for years. You must process through this. There's no roadmap for exactly what that looks like. It's different for every person, but it is a little bit of a red flag if someone's just completely stoic, stone-faced, and they get through the grieving or the funeral portion, and then now a month later, we're fine. I'm fine. I'm not going to
What
talk
do you-
about it.
Everybody's different, but what do you do about that?
That's where our social worker comes in. That's where the social worker needs to dive deep into what's happening and figure out what resources we need to find for the family or this particular person. Again,
Let me go back to
very
what-
individual.
Very individual. Let me go back to where I started, Jessica. It takes a special person to do this, doesn't it? To be involved in all of this.
It absolutely does. Because our hearts just don't shut off after we walk out the door of somebody who just passed.
Yep.
We remember them. Sorry.
You go to their funerals, I suppose. You
I
hold
have
hands
been.
with the relatives and the friends.
Yes, whenever possible, I like to attend. There are times when, you just know, like, you just know.
Yeah.
So, but yes, like, I know every single patient who I have helped through their process.
And remember them, yes.
And I remember them. They are people to me. And they touched my heart. And so I just feel very, it does take a special person. Not everybody can do this. It is hard work that is very, very humbling. And at the end of the day, I know that I've made a difference, even if it was just for a moment. I've helped people and I've changed their lives. And
Everybody has a story, don't they? Yeah. Everybody has a story.
Everybody does.
You see people walking around and you don't know their story, and everybody has one, huh?
Everybody does have a story. Everybody has a past. Everybody has a history. Everybody has some kind of a family dynamic. And it's our job. I hate to call it a job because this is not a job to me. But it's our work to go in and dive into that and see how we can help serve the patient that Jen's talking about. I'm fine. I don't need anything. I'm fine. It's our job to go in and see how we can and make it fine for every single person that's part of that patient's care, and the patient and honoring their wishes. When normally at this part of their life, they have decided, I don't want to seek treatment anymore. I've had enough chemo. I've had enough radiation. My kidneys no longer work. My heart's tired. They know that it's their time. So it's my job and my honor to respect their wishes and give them their dignity at the end of their life.
How are you doing on employees, trying to hire people? Everybody's having trouble, but this seems you're right. What you said, Jess, this is more than a job. It's a dedication. But Jen, about hiring people, are you always looking for people? You're always looking to hire people?
We are, but we're always hiring good people. We're looking for the fit with our team, our philosophy. Like Jess said, not everybody can or wants to do this. It is hard. But
do you have to be an RN? Does someone have to be an RN to be involved in this?
I am not an RN. I am not an RN. By background, I was a dental hygienist. I made.
That's all right. You want me to clean my teeth? That's right. Go ahead. I'm sorry.
Right. So I made a career change. But it does take a certain person, and we as a team like to interview and feel good about having someone join us. I feel like we're a pretty tight-knit group, and we all kind of operate from the same space. We're here to serve. It is a job, but it is a calling. That's what we're looking for.
Auburn Crest Home Health and Hospice. David, the key is to reach out. If you think you have someone in need, the key is going to be to reach out. Yes, I've learned you get referrals from hospitals and doctors and from others, but for those who see this, the key is going to be to reach out to Auburn Crest, right?
Yes, sir. Anybody is welcome to call our office. We'll ask a few questions, find out what's going on, and then we will get the information and call their doctors ourselves, gather the information, and get the orders from the physician and help them.
Don't worry about the money. Well, I guess don't worry about the money. This sounds so expensive. I mean, to have somebody to come by, and fix your air conditioning is a $500 to $1,000 job just to have them show up some. So, but and medicine is known for being so expensive. But in the case of healthcare and hospice, don't worry about the money. We can figure that out, right?
Exactly. On home health and on hospice, the home health company pays for the wound care supplies. We pay for incontinence supplies. We pay for anything that's involved with your care. The insurance companies pay us, and then we take that money and pay for your care. So
how do we contact you, David?
Our number is, I don't have it memorized. Anybody got our number there?
Here's the thing. Here's how we'll excuse you. Nobody knows telephone numbers anymore. We all have cell phones, and we find names, and we put, if I want to look you up, I look up David, and then if I can't remember your last name, I go down the list and look at all the last names. So that's why none of us even know.
You can simply Google Auburn Crest Home Health and Hospice in Draper, Utah.
Or go to the website, Auburn. What is the website name? Auburn Crest?
Auburn Crest Home Health and Hospice.
Okay, and that's how we can find you. All right. Well, I really you've shared an awful lot of great information. David Woods, the administrator at Auburn Crest Home Health and Hospice. Gene Wilburn, the marketing director over there, who you can expect to visit from time to time, and Jessica Barnes, nursing director over at Auburn Crest. I really want to thank you for this very informative few minutes we've spent together.
Thank you, Bill.
Thank you.
Thank you.
That'll do it for this edition of the Bill Gephardt Show podcast. And now for the latest in local breaking news coverage 24/7, check out GephardtDaily.com. See you next time.